Assalamu alaikum everybody, good morning. Today we'll talk about recurrent epistaxis-case presentation, supervised by Dr. Jamal Jawad and presented by me, Abeer Melbari RC. On 15th of September 2020, a 26 years old lady came to the clinic complaining of nasal blockage, nasal discharge, post-nasal drip itchiness for more than 10 years. She's an atropine abuser for 2 years. And in examination, there was deviated nasal septum, pale mucosa, and large inferior turbinate bilaterally. CT paranasal sinus done and showed by a deviated nasal septum with enlargement of inferior turbinate. So patient booked for septoplasty and bilateral SMD. On 17th of October, all investigations were in the normal range. The hemoglobin was 12.5, and the patient underwent septoplasty with bilateral SMD. Bilateral internal splint were inserted, and there was no PAX. Patient tolerated the procedure well and discharged home with no complications. Post-op day 3, she came to the ER complaining of epistaxis, minimal amount, about 2 teacups, and stopped spontaneously. On examination, there was no active bleeding, and elastic internal nasal splints were in place. So we reassured the patient and discharged her home on atropine drops. Post-op day 4, patient came to clinic for post-op follow-up, and there was no bleeding, and the internal splint were removed. Everything was stable and good, and patient went home. Post-op day 6, she came to ER complaining of bilateral epistaxis, and the hemoglobin dropped to 11.6. Bilateral nasal packs were inserted, and patient is prepared for ER. Dr. Jamal found necrotic tissue at the area of posterior end of inferior turbinate, and the bleeding area was determined. Patient did the procedure well and shifted to recovery area. In recovery area, patient started to bleed again. So shifted again to OR, and under general anesthesia, she underwent surgery of sphenopalatine artery and its septal branches. Hemoglobin dropped to 8.8, so we transfused 1 unit of factor BC. And patient went to the room without any pack, and she was on tranexamic acid. As day 9, patient was dry for 36 hours, then started to complain again with of intermittent oozing of blood from the right side, small amount. So here we inserted the nasal pack, and we start counseling regarding the angiography. COVID swab was taken from the oropharynx, so we can refer the patient to other hospitals. Day 11, patient was referred to King Faisal Hospital for embolization, and on day 13, angiogram done for her showed no evidence of active hemorrhage or definite lesion explaining the recurrent epistaxis, but they did a prophylactic embolization of bilateral internal maxillary artery, and the pack removed after 3 days. Patient discharged home in stable condition. But this is the case presentation. I will talk about the epistaxis. This is a quick review. We can classify, first of all, epistaxis is bleeding from the nose, and we can classify it to anterior and posterior. Anterior epistaxis is the most common epistaxis, and it's about like 80% of the cases. And the most responsible area for the epistaxis from the anterior side is the Kesselbach or little area. Little area, as you see here, it's about the vascular we have internal carotid and external carotid. The internal carotid will give ophthalmic artery, and ophthalmic artery will give anterior and posterior ethmoid artery. For the external carotid, give branches. Maxillary artery will give sphenopalatine artery, and it will give branches. And also, external carotid it gives lesser palatine and greater palatine, and facial artery also giving the branches to also the spinos. This is all in the Kesselbach or little area. The other type is posterior epistaxis. The most responsible area is the Woodruff plexus. It's about 10 to 20% of the cases. The most responsible vessels are sphenopalatine artery or posterior ethmoid artery. In our case, it was posterior epistaxis, and usually posterior epistaxis will go to severe and will go to embolization at the end or any surgical management. So for management, we have to go systematically. If there is any active nasal bleeding, we have first to know if the patient is stable or not. If the airway is secured, the breathing and circulation, blood pressure and pulse all okay. So if the patient is not stable, we have to resuscitate the patient first. Then, if the patient becomes stable, we can go for and before that, we can start with the first aid, squeezing Eli and bending the patient forward, the head forward, and give also xylometazoline vasoconstrictor to stop the bleeding. If the bleeding stops, we have to observe the patient and consider packing if there is any recurrence. If the bleeding persists, we'll do rhinoscopy to identify the bleeding site. So if we could identify the bleeding site, we can cauterize it by silver nitrate, or we can put anterior nasal packing like Mirasil, balloon, gauze. We can go for bilateral packing if it's severe also. So if the bleeding stops, we have to address the cause and prevention of recurrence. Like if the patient is on anticoagulants, we have to consult the doctor who prescribed the anticoagulant medication to see if we can hold it. If the blood pressure is not controlled, we have to control the blood pressure. If there is any bleeding disorder or hematological problem, we have to involve the hematology to manage the case. So if the bleeding persists, we'll go for posterior packing, and here we have to admit the patient in the hospital, and we'll keep the pack for 48 to 22 hours. And always, if the patient is in pack, we have to give antibiotics to prevent the infection. So if the bleeding persists after all this management, we will go to surgical management, either ligation, cautery, or embolization. So this is a quick review on embolization. First of all, we'll talk about the indications. Like our case, uncontrolled epistaxis with a failure medical management after 72 hours, identifiable bleeding site, nasal anomaly precluding packing, patient refusal or she cannot tolerate or he cannot tolerate the packing. If the site of the bleeding is inaccessible surgically, if the candidate is not operable or inoperable, if there is any bleeding or rebleeding after surgical arterial ligation. Right. For the success rate, I've looked up for the many articles, all talking about percent from 82 to 85, reaching 95 to 97 success rate. So how will do embolization? Under local anesthesia, angiography is used to identify the bleeding point and display the nasal vascular anatomy. It's essential to exclude any abnormality like arteriovenous malformation, aneurysm, fistula before the embolization. Right. This is a small, kind of simple video because when I looked up for the embolization, I wasn't any picture يعني كيف حيكون extravasation of the contrast. So here's a small or simple video showing the extravasation of contrast. Right, here's the angiography done, and this is the vascular anatomy. You can see after they inject, you can see the extravasation here, very clear. Right. Once the bleeding vessel is identified, we'll fine catheter is passed into the internal maxillary circulation, and particles like microcoils and polyvinyl alcohol are used to embolize the vessel. In our case, we use microcoils, and they're also doing ipsilateral facial artery embolization in order to prevent recirculation or collateral blood supply. So for material used in embolization, Dr. Jamal asked me to look up for this material, and I found this great article. It's about common embolization agents used in vascular intervention radiology. It's published in 2014, and this schedule shown in the article showed the classification of embolic agents. We have temporary and permanent. Temporary like a gel foam, gelatin sponge, but we're not using this kind of embolic agent. We are using always a permanent. So permanent we can divide it into non-absorbable microparticles, mechanical agents like coil, and liquid agents.
Monitor.
Right. For advantage of embolization, it can be diagnostic and therapeutic in the same time, and it can be repeated, and it can be done under local anesthesia. بالنسبة disadvantages, risk of embolic event, pulmonary emboli or stroke, require active bleeding, not available in all hospitals, and the complication also cerebral embolization with hemiplegia, blindness, skin necrosis, facial pain and edema, groin hematoma. This is the most common complication in the catheter side. But this is an article of transcatheter embolization and management of epistaxis in 2013. Um, and there was a case of a patient with trauma with nasal fracture and severe epistaxis. This picture in the left side is showing the injection of the contrast, and there is a pooling, as you see here in the arrow, a pooling of contrast in the area of distal internal maxillary artery and sphenopalatine artery. The picture in the middle is showing the post-embolization of internal maxillary. As you see, the branches are gone or disappeared. And this is a picture of late phase of injection, showed pooling of contrast here, resulting from persistent ethmoid artery supply. So they just wanted like highlight the point of collateral or possibility of having another artery causing the bleeding after even the embolization. This is another case scenario. This patient came to Dr. Jamal in 2012. She is 33 years old, female, came complaining of nasal blockage, anosmia, headache, and slight proptosis, blurred vision. This is the CT of her. As you see, all the nasal cavity is ossified, and all the sinuses are ossified also. So she underwent FIS 4, and during FIS, Dr. Jamal found non-pulsatile swelling in the right internal carotid artery area. So patient tolerated the procedure well, discharged home without any complication, but after a few days, she came to ER with massive nasal bleeding, and she was shocked. There was undetectable pulse and irrecordable blood pressure, weak carotid pulse. So after resuscitation in ER, they gained the pulse again. The blood pressure started to pick up to 90/60. IV given and cyclocarbon also given. Patient became oriented to time, place, and person, so they consult ENT. When they did the investigation, they found the aneurysm, as you see here, in the internal carotid artery. So they did ballooning for 8 hours, and they did occlusion of internal carotid artery with coil. This is pictures of CT post-embolization, as you see here, the coil. And this is also plain X-ray post-embolization. There is also a CT post-embolization showing the coil. So for taking home message, do not underestimate nasal bleeding. It can be fatal. And always manage your patient systematically and keep in mind the option of embolization. These are my references. And thank you.
Thank you, Dr. Abeer. Allah يعطيك العافية. نترك المجال المجال لدكتور لدكتور جمال إذا بحب يعلق أي شيء قبل ما نفتح المجال للأسئلة. دكتور جمال جواد، عندك أي تعليق كون الحالة؟
Good morning, everybody.
Good morning.
Thank you, Abeer. It's a nice presentation. Well done. Very informative. Regarding the last case, I just wanted to show you, for your knowledge, to see the coiling of the internal carotid artery, because this is a very rare complication, like having aneurysm undetected preoperatively. And during the operation, I noticed the swelling in that area, so I didn't manipulate that area. And then she developed the bleeding, and we did angio and showed the aneurysm. It's a late diagnosis, but anyway, everything was done, and she tolerated the coiling and blockage of the carotid artery.
دكتور الدكاترة حدا بحب يسأل أي سؤال، حدا عنده أي استفسار لدكتور جمال أو دكتور لبناء أو دكتورة عبير؟
Yes, Dr. Ibrahim, I have a question. Thank you, Dr. Abeer, for the nice presentation at first. Regarding the first case, why did they do bilateral angiography for both anterior maxillary arteries? Why bilateral? Since the patient was bleeding from one side mostly.
Javier. Or sometimes they do it bilaterally especially when they didn't find a bleeding site. They do the embolization bilaterally, probably if there is cross circulations from the other side.
Dr. Jamal, according to your opinion, what is the cause for her bleeding?
I have no idea. But Dr. Aqil went with me in cauterizing the sphenopalatine, and the bleeding stopped, but the area and the bone didn't look healthy. I don't know why. Probably because of a disease, an infection happened after post-operatively in the area.
For the second case, can we get back to the image which shows the aneurysm?
Doctor?
Can you please get back to the image which shows the aneurysm?
Yeah, you mean this one or another?
Yes.
Yeah, this one.
Okay.
So, Dr. Jamal, the patient at first, how was the bleeding stopped for the second case before the angiography at that time?
We packed the patient and the bleeding stopped. It's controlled with the packing. Of course, with the pressure, the artery will stop bleeding. And we took her immediately and did angio, and we discovered this aneurysm. The most important thing is what I forgot to mention is that you have to assess the CT scan properly before the operation. For us, if you can see the CT scan, the sphenoid sinus walls are all eroded, and that's why I took a lot of care during operating in that region. I suspect that I will see a carotid artery or an optic nerve. So assessing the CT scan pre-operatively is very important. And that's why I saw this bulging, but it wasn't pulsating, even though I didn't touch it. And then when we reviewed the CT scans, the pre-operative CT scans, they noticed, the radiologists, that there was a suspicious of aneurysm in that area. But of course, they didn't report it at that time.
Dr. Jamal, there's always a saying that the internal carotid artery embolization carries a risk for stroke and blindness.
Yeah.
So So for
Yeah,
this
but
patient, it was life-saving.
yeah, you see what they do? They do ballooning. They pass a balloon, and they inflate it and keep it there for 8 hours and observe the patients for any neurological problems. If there's no neurological problems, they do the embolization and they insert the coil, and that's what happened. Yeah, there is a possibility. It's not with the coiling. It's when we use other materials like the polyethylene alcohol or gel foam. That's where you have the peripheral emboli can affect the ophthalmic artery and other arteries and causes stroke and blindness. But with the coiling is a better result. There is no peripheral embolization.
Okay, thank you so much.
So Jamal, for the second case, let's say you've noticed the aneurysm before the surgery, or the radiologists have reported before the surgery. Would you have gone for embolization before doing the surgery, or what precautions would you do?
Well, we have to be very careful. I don't know if we should do embolization before surgery. Of course, this needs to be dealt by neurosurgeons. It's very difficult because you have the infection, a fungal infection in the area, and invading the base of the skull and the sphenoid sinus. And yeah, I would say the neurosurgeons will go for embolization or ligation of the artery before we do the FES.
Yeah. I don't know if anybody knows, maybe this is non-ENT question, maybe more to interventional radiology, but how specific can we go in embolization? So in the first case, they did facial artery embolization bilateral, while the bleeding might be just from the sphenopalatine from one side or both sides. So can they go specific and for narrow branches like sphenopalatine, or they just do major vessels embolization? I don't know if anybody has this, the answer to this question.
For the small vessels, they, as I said, they don't use the coils. Sometimes they use materials which can be dislodged and cause peripheral embolization. So most of the radiologists now use the coils, and they have small fine coils. I don't know if they should go further down the maxillary artery branches and embolize every branch. I have no experience in that, but mainly they sometimes, yeah, they block the sphenopalatine itself. And the maxillary artery, because the maxillary artery has so many branches. There are so many branches. Before we used, I did one case of epistaxis, which I had to ligate the maxillary artery at that time through a cadwalk approach using the microscope. And I think I used 4 or 5 clips to ligate branches of the artery. Embolization is very helpful nowadays. It's very good, and it is used. If you read about embolization now, it's the state of the art for a lot of things, from cancer to epistaxis to other things.
Okay. There's a question from Dr. Hisham Turab. He says, can we consider nasal granuloma or antrosphenoid syndrome, or antiphospholipid syndrome as a cause for the massive nose bleeding in the first case?
There was an examination, and there was no granulation tissues as such. And if there is any vascular anomalies, it would have shown during the angiography. I don't know, Dr. Hisham. Does that answer your question, or? But as I said, we don't know what's the cause of it. What's this massive bleeding? I mean, uncontrollable bleeding. It's just only the area wasn't very healthy at that time. Maybe of an infection.
Yeah.
I don't know.
Currently, in the COVID-19 era, there is lots of people using herbs and over-the-counter, boosters for immunity. Some of these herbs may increase the risk of bleeding pre and post-op. I don't think this will cause as severe bleeding as this case, but have you asked the patient if she is taking any herbs?
She's atropine user. She's atropine user.
Just atropine, yeah. I mean, I've got a case like maybe Dr. Hamad, I remember it 6 months ago. A patient presented with recurrent bleeding and has anterior packing several times in other hospitals for less than 1 day. And he presented to us without any surgery. He's just spontaneous bleeding with severe bleeding, and he did not stop before Dr. Hamada put anterior and posterior balloon packing for the patient. And when we did the bleeding profile, it was a little bit elevated, and we prepared him for surgery. But the next day, after asked him, we found the coagulation profile is high, and we asked him, he was taking some kind of drink من العطار، بعرفش ايش المشروب اللي كان ياخذ وقتها، بس those medications may increase the bleeding profile. So he stopped it, and after 2 days the bleeding stopped spontaneously and the packs removed, and he went home without surgery. So sometimes you have to take care of this in the history before doing the surgery or after that. Any other questions from the other colleagues? We still have a couple of minutes.
I want to talk about also the infection as a cause of bleeding in the nasal surgery or post-nasal surgery. Yeah, a lot of cases or many cases we faced before also with late bleeding post-surgery, like 3 to 5 days or 7 days sometimes post-surgery. And the bleeding sometimes is severe also. And when we enter to the OR, you will find a lot of necrotic tissue and oozing from everywhere in the tissues in the surgery, middle turbinate or the inferior turbinate. Usually some cautery with antibiotic, the same management as post-tonsillectomy bleeding, to start antibiotic early if there's early signs of a bleeding. I think this will be also should be focused on.
Yes, that's true. Especially if the bleeding is from the inferior turbinate. Yes. Good. So we still have 5 minutes. I think we've done a very good presentation. Dr. Abeer, thank you very much, and thank you, Dr. Jamal, and thank you all for the discussion. We always hope for such a discussion in all the seminars rather than just saying.
Can I raise a question?
Yeah.
What is the cause of this aneurysm? Can anybody answer? Well, it could be congenital aneurysm.
Yeah, it could be a thinning of the bone in the sphenoid sinus due to the fungal sinusitis. Maybe thinning of the bone increase the risk of the aneurysm, and the patient has some sort of intracranial pressure increase, so it bulged through the thin bone.
And there is other thing. It could be due to the fungal infection, what we call mycotic aneurysm.
Yeah.
Okay.
Dr. Hisham is asking again, could it be related, the bleeding in the first case, to oral contraceptives? Or is she taking oral contraceptives? Does that increase the risk of bleeding? I don't know.
Yes, oral contraceptives can increase the risk of bleeding.
Mm.
But not in this matter, yeah, Dr. Hisham.
Morning, everyone.
Okay, very good. So, very good. Thank you very much, Dr. Jamal, Dr. Abeer, and all the colleagues. Next week we will have Dr. Isra talking about the macroadenoma case for Dr. Jamal also. Prepare your questions for such a very good discussion. And the last week of this month we'll have Dr. Aqil and one of the interns will be speaking about darkocystoinoscopy endoscopic PCR. So, anybody has any question? Or we can stop now.
السلام عليكم. سامعني إبراهيم؟
أيوة دكتور حسام سامعك تفضل.
عندي مشكلة في اليوم المايك في مشكلة ولكن anyway excellent presentation عبير مرة ممتاز الله يعطيك العافية. يمكن سؤال للجميع to pack or not to pack after nasal surgery. يعني I met few people they said they don't put anything in the nose for pest or septum and sometimes I do and sometimes I don't. So any analysis or meta-analysis or study showing the benefits of packing or we اشتراك دكتور جمال.
Dr. Husam, for the last 20 years, maybe I didn't put a pack in the nose post-operatively, neither septoplasty, turbinectomy, or fist. I can't remember that I had a bleeding post-operative. Sometimes they get, of course, as Wissam said, secondary bleeding after a week or 10 days. But immediate post-operative, I can't remember. I took the patient back and to OR and inserted. I don't know. I haven't read an article or analysis regarding this thing. It's a good idea if we do some study in our hospital.
I don't know if there is an article about that, but from my little experience during my residency, all the nasal surgeries we put back Mirocell for 1 day, and the second day we remove it. But I noticed that when we remove the pack, there is lots of bleeding, and we start to stop the bleeding, like if we are in the surgery, like with atropine packs, compression for like 10 to 15 minutes to stop the bleeding after removing the Mirocell after any nose surgery. So I think putting a pack in a patient if he is not bleeding in the intra-op, you're just postponing the treatment of the hemostasis to be done in the ward like after 1 or 2 days. Unless if you put it for a long time, and if you put a pack with lubricant, like I think Dr. Hussam, he puts the pack in a glove, and it's lubricated, so it's easy to remove. Because if you just put a dry Mirocell pack, sometimes it's traumatic to remove it and cause bleeding. For me, when I came to after the residency, I started doing private surgeries, and there was no resident with me, so it was difficult for me to go back to the hospital to remove the pack after each surgery. So I stopped putting the packs unless the patient is bleeding heavily after the surgery. And I didn't, notice any problem with bleeding since that time, at least primary bleeding. What I do is I put a small gauze soaked with xylocaine with adrenaline, the same material we use it for the infiltration. I put it after I finish the surgery for 5 minutes till the patient is fully awake and the tube is out. So the bleeding will not cause, mess in the OR, and he will not spit or bleed while the anesthesia is waking him up and transferring him to the other bed. And whenever the patient is in the other bed and the tube is out and he's calm, I remove the pack intra-op, and I just put a mustache, and usually there will be no bleeding. The main bleeding after OR in the first 1 hour is just the patient trying to the increased intrafacial pressure by manipulation of the patient and removing the tube. This is my opinion. it changes it?
For me also, as Dr. Jamal said, for the last 10 years, I did not put any packs inside the nose after surgery. In septoplasty, only the splints, we put to support the septum, prevent adhesions. Else, no packs at all for the last 10 years. And we never faced primary bleeding post-surgery. Even the small oozing that you can see in the sinuses post-surgery, it will stop by itself.
So thank you very much. Thank you, Dr. Abeer. Thank you, Dr. Jamal. And thank you all.
Thank you. Thank
See you
you.
next week. Have a good day.